Hello everyone, myself Prateek Machiwal. I am a final year MBBS student at All India Institute of Medical Science, New Delhi. I am going to start a series on clinical case discussion on various clinical cases related to medicine and surgery. And this is the first video of that series, that is cough. You have to do the microbiology and pathology part first, and then you can attend the clinical case discussion sessions. Let's get started. Okay, so let's start the video. We would like to discuss firstly the classification. Then classification is also further divided on the basis of etiology, duration or type. Then we would like to discuss about various kind of expectorations. Then the hemoptysis, it's a kind of expectoration only. Then after discussing all the 3 points, we would like to take a clinical case and what all investigations we can do. So first we have to see the classification. Firstly on the basis of etiology. Etiology means what's the cause. Let's start with the classification with the duration actually. We know that the cough can be acute, it can be chronic and it can be subacute. Now when we will call a cough as an acute cough if the duration is less than 3 weeks, and if the duration is more than 8 weeks, then we would like to call it as a chronic cough. Now if the cough is between 3 weeks and 8 weeks, we would like to call it as subacute cough. So this is the classification based on the duration. Acute cough, chronic cough. Less than 3 week acute, more than 8 weeks is chronic, and in between we would like to call it as a subacute cough. Now on the basis of etiology we can divide as respiratory causes of cough, and it can be the non-respiratory causes of the cough. Now if a patient present acutely, like the cough is less than 3 weeks, then what all respiratory causes it can have. So if it is sudden onset, just think, if it's in sudden onset, what it can be? Asthma, it can be foreign body, especially in the children's, it can be asthma. It can be whooping cough and also the asthmatic bronchitis. Alright. Then if it's a non-respiratory cause, so non-respiratory cause can be cardiac failure. Yes, the cardiac failure can present as a sudden onset of acute cough, and it can also be some gastrointestinal problems like GERD. Yes, GERD can also present as an acute cough. Then these are the like sudden onset acute cough. The other causes of acute coughs include like pulmonary embolism, that can be some sort of pneumonia, and also the infection of the trachea and the bronchus. So the bronchopneumonia and the tracheobronchitis, and also pulmonary embolism and some viral pneumonia. Now we would like to see the causes of chronic cough. Chronic cough, all the chronic disease like asthma, COPD, tuberculosis, any kind of lung malignancy will produce chronic cough. The chronic cough, the non-respiratory causes of the chronic cough can be drug induced. The very important example is the ACE inhibitors. The ACE inhibitors will cause chronic cough and it is drug induced. What is the mechanism of ACE inhibitor causing cough? We all know that ACE enzyme also helps in the degradation of bradykinin, and the ACE inhibitor, if you give the ACE inhibitors like enalapril, the bradykinin level will increase and the bradykinin will. Now what about subacute cough? Subacute cough is something which is in between acute and chronic, so it will have overlapping causes of that. For example, GERD can cause subacute cough, and also Tourette syndrome. We all know that Tourette is a psychological disorder. It can also cause subacute cough. And other causes can be tuberculosis, pneumonia, it can be pertussis, it can be bronchiectasis, and it can be post-viral ptosis syndrome. So you have a basic idea about what is acute, what is subacute, what is chronic, and then we have to divide it in respiratory causes and non-respiratory causes. All right. Now, we would like to classify it on the basis of type. We would like to see some of the types, and also I'm going to show you some videos, some clinically relevant videos. How can you listen and identify the cough? Now, before that, I would like to tell a point that if there is chronic cough and the chest X-ray is normal, any patient that will come along with cough, we would like to order a chest X-ray. If the chest X-ray is normal, what we can think of? We can think of some drugs, for example, the ACE inhibitor, and that the chest X-ray will be normal. We can think of some aspiration which have not caused, which is not picked up in the X-ray, and the tropical eosinophilia. So these three cause, you must know that the reason of the chronic cough along with the normal chest X-ray. Now, okay, now, so we would like to see the types of the cough, the various type of cough. The cough can be dry cough. If the sputum is not there, it can be productive if there is a sputum production. Now, what is bovine cough? Bovine simply means cow, right? So it resembles the sound of the cow. Now, how bovine, what's the reason of the bovine cough is there is a loss of expulsive nature, right? Loss of expulsion is there, and why it is there? There is a damage to the recurrent laryngeal nerve. Recurrent laryngeal nerve. So if there is a damage to the recurrent laryngeal nerve, then the pharynx is not going to open properly, right? The vocal cords are not going to open properly. Then firstly, the recurrent laryngeal nerve is damaged, so the voice will be hoarse. There will be hoarseness in voice, and also the opening of the pharynx is not going to open properly. That is why there is going to be a bovine kind of cough in which the expulsion is going to be affected. There is going to be the loss of the expulsion. I am going to show a video also for the same, right? Then we have the croup. As we all know, it's very common in the children, so it's seen in the parainfluenza virus. So these are the kind of cough we must know: the dry cough, the productive cough, bovine kind of cough. If there is a recurrent laryngeal nerve involvement, recurrent laryngeal nerve involvement can be due to any kind of tumor around that, and the croup. Now there is one more modality that is known as paroxysmal cough. So what is paroxysmal cough? It's it's like there is going to be sudden intense bout of coughing, right? What I did is sudden and intense bout of coughing, and in between there is going to be spasm, right? And it is very severe that the patient can have difficulty in the breathing, and it can have also vomiting and exhaustion, isn't it? Now the reason of the paroxysmal cough, it can be pertussis. Pertussis, as we all know, it's also known as whooping cough, and there is going to be the violent coughing, and it is going to be followed by a whooping. It's especially occur in the children. It's like I'm not doing it properly, but I'm going to show it in a video. Then the asthma, it's also the paroxysmal cough, chronic bronchitis, and in any kind of aspiration. So the simple basic idea is there is going to be a paroxysms of the cough, right? Paroxysmal cough. There is going to be bout, there is going to be spasm of cough in between. Now this is theory point that the whooping cough disease progression, there are going to be three stages: stage 1, stage 2, and stage 3. That's early symptom, late symptoms, and the recovery phase, and you must read it in the microbiology section. Now, okay, I have to show you the videos. I'll show you some videos of dry and sputum. You know, dry and productive cough are not very difficult to differentiate. You just can ask with the patient if there is sputum or not, then you can differentiate. I would like to show you how the croup sounds like, and how the pertussis, like whooping cough, will sounds like. I can have the mic. So this is how the croup sounds like. Hope you will get the volume. It's a typical whooping cough. Now I'm going to show you the whooping cough. Now I would like to discuss about the expectorations, right? The expectorations, the normal expectorations is 10 to 15 ml in 24 hours is normal. That much expectoration is normal. But when we would like to call it a bronchoria, when the production is more than 100 ml per day, then we would like to call it as, let me write it, then we would like to call it as bronchoria. Now, it can be occur in bronchiectasis and it can be in the lung abscess. If the secretion is very much, there are only two causes we have to remember, that is bronchiectasis and then is lung abscess. And how we can differentiate between that? If the amount of secretion is large and it is purulent and it is foul smelling, then it is bronchiectasis. But all these three features, if they are associated with fever, then there is going to be lung abscess, isn't it? Then we can differentiate the two causes, that is bronchiectasis and lung abscess, the two causes of copious amount of sputum production. We can differentiate it on the basis of fever. Now on the basis of quality, we have mucoid, mucopurulent, purulent, and there are some color associated with the cough. Now just think that if there is any condition related to the bronchus, right, if there is any kind of inflammation and secretion has increased, for example in the bronchial asthma, then there is going to be a mucoid kind of cough, mucoid kind of sputum. And when is going to be purulent? When there is intense infection. The infection is very much, and it can be in the lung abscess and it can be in the bronchiectasis. And we have already discussed that how we can differentiate between the lung abscess and the bronchiectasis. If it's in purulent and it is large amount and along with the fever, then it's going to be the lung abscess, and if it's without fever, then it's going to be bronchiectasis. Mucopurulent we can see in various kind of infections. The rust color purulent sputum, purulent is there, that means it's a kind of infection, and the rust color, it is going to be classically seen in the pneumococcal pneumonia. And if it's a jelly like and sticky sputum is a characteristic of Klebsiella pneumonia. And if it is bloody tinge foamy sputum, if they are going to be foam, then foam is pink color, foamy sputum is going to be in the pulmonary edema. There is going to be froth and foam. The greenish, as we all know, green is Pseudomonas. Everywhere in the medicine, if there is going to be green, there is going to be Pseudomonas. If there are granules which are yellow or blackish in color, it's seen in actinomyces, and in anchovy-source sputum is seen in the amoebic abscess. We know that anchovy-source sputum, it's a very common question in microbiology. It's in the amoebic abscess. And the black is also known as melanoptysis, and these are nothing but the carbon particles. When in the chronic smoker, the carbon particles get deposited and they come out as a cough. So this is nothing but the carbon particles. And the foul smelling is there. We know that foul smelling, whenever it come in microbiology, it's anaerobic infection. So if there is any anaerobic infection in the lung, there are going to be foul smelling. So we would like to see it again, that the normal production is 10 to 24 ml, 10 to 15 ml in 24 hours. But if there are large amount, that is more than 100 ml, very large amount, you have to remember two causes, that is bronchiectasis and lung abscess. Then we have various color in the sputums. For example, rust color sputum, we have seen the rust color was in the pneumococcal. If it's sticky, then it's Klebsiella pneumonia. If it's foamy sputum and it's blood tinged, then it's going to be pulmonary edema. They're going to be pink in color and frothy. And if it's greenish, green is, we all know that Pseudomonas. If there are granules, then it's actinomycosis. If anchovy source, then it's amoebic abscess. And black, it's nothing but the cigarette smokers have. these kind of sputum. And if it's mucoid, we have to think of two causes, that is bronchitis and asthma. If it's mucopurulent, then it's infection. It's purulent, and it's purulent, then it's again infection, and it can be due to bronchiectasis and lung abscess. That's it. The other thing we have to discuss is the causes of the hemoptysis, right? So there is blood along with the cough, that is hemoptysis. Now there can be various causes. Various causes means hemoptysis means there is blood. So the most common cause we can think it of is vascular disease. Any kind of vascular disease, for example pulmonary infarction, can lead to hemoptysis. Then we can also think of some parenchymal disease, like for example parenchymal tuberculosis, any kind of fungal infections, if there is any lacerations, if there is aspergilloma, lung abscess, anything which is also affecting the blood vessels and adjacent blood vessels, so that can also lead to hemoptysis. If it's there any kind of bronchial disease, for example bronchial carcinoma, bronchiectasis, and acute and chronic bronchitis, which is also affecting the blood vessels, it can also lead to hemoptysis. Some sort of cardiovascular disease, for example acute left ventricular failure, we all know that pulmonary vessels, the pressure in the pulmonary vessels is going to increase, that can lead to hemoptysis, that can lead to the leakage of the blood. And obviously hematological disorders, for example if low platelet counts, and if the coagulation profile is not normal of the patient, it can lead to bleeding in various sites along with hemoptysis. So the causes can be bronchial, it can be parenchymal, it can be the vascular causes, can be cardiovascular, and it can be hematological, and we have to rule out all of them. Now we are going to start the clinical case discussion. Let's see the case first. There is a 67-year-old man is admitted to the hospital with myocardial infarct. Okay, and following the successful coronary, just a minute. So following a successful coronary intervention, he is discharged on antiplatelet therapy and atorvastatin and enalapril. So he had myocardial infection, and now he is receiving 3 medication. One is antiplatelet, its name is not given, it can be clopidogrel or something, atorvastatin and enalapril. We all know that enalapril is a ACE inhibitor. Now when seen again 2 weeks later, he is very well but complained of a persistent hacking cough, and he has been keeping him awake at the night. What can be the cough? Persistent hacking cough after the drug administration. And what's the drug? So enalapril, that is ACE inhibitor. The simple diagnosis, it is drug induced cough due to the ACE inhibitor, because we all know that there is one substance that is known as bradykinin. Bradykinin is degraded by the ACE enzyme, and if you give the ACE inhibitor, the bradykinin is gonna increase and it's gonna cause the cough. So what can be the solutions for that? What we can do is we can start on the ACE receptor blocker, the ACE enzyme receptor blocker. We can start with that ARB like the Wartons, like the Valsartan. It's a simple solution for that. Now we would like to come upon the investigation. What investigation we can do in the cough? It always depend upon the situation. For example, if it's an asthma, we have to do the spirometry part. If it's a tuberculosis, we have to examine the sputum, we have to do sputum examination, gene expert, and chest x-ray is what something it's common in all among them. If a patient come with the cough, we have to do the chest x-ray, and the rest all depend upon the situation. As I have said, like in the asthma, we have to do the spirometry. For example, in the tuberculosis, we have to do the sputum examination. If it's a productive cough, we have to do the sputum culture. Any kind of productive cough, we have to do the sputum culture to rule out the various causes, the various infective causes of the cough, and various diagnosis we can make clinically as well. Thanks for watching this video till the end. This was my first video on clinical case discussion series, and this is my first video on the YouTube as well. Let me know in the comment section about various feedback and mistakes which I have made. Thank you.